welcome to this class on metabolic bone diseases. It's a topic which is extremely important, especially for the juniors. First years, you get a lot of spotters in the exam from this. So that's how I'm going to approach it. We'll be discussing it in a case-wise approach. All right. So good evening to all of you. We'll be doing it in a case-wise approach, and you do get theory questions from this also as to how will you get a long answer on metabolic bone diseases and their approach. So this entire class is a long answer question, and then you also get a separate long answer question on osteoporosis and how you go about approaching it. So I'll be covering that in a bit of a detail. Others will be more or less what are the imaging findings, how do you diagnose it if it comes as a spotter, whereas osteoporosis will be doing it in a long answer approach as well, because that's where you get a detailed question to write. Okay, so that's going to be the approach. The most common metabolic bone disease that we have indeed is osteoporosis, but I'll be looking at it in the end. First, we'll finish off individual cases, spotters, and then we'll go about osteoporosis theory. Okay, so that's how the class is going to be. Just gonna share the screen. All right, okay, so let's start. Do keep interacting and letting me know what you think about the case. Fine, so that's how I have made the presentation, in which you'll be able to see a few cases and you'll have to diagnose, and then we'll discuss that condition. Okay. All right. All right, let's start. So a bit of a theory before we begin with metabolic bone diseases, a bit of anatomy and physiology. So anytime you are asked a question on this, always start with this, why do metabolic bone diseases occur and what is the broad classification of it. So anytime we talk about the structure and the anatomy of the bone, there are two parts to it. One are the cells, which we obviously know we have osteoblast, osteoclast, and osteocytes. And then we have the extracellular matrix. When we talk about the extracellular matrix, we have organic and inorganic matrix. Okay, so even though we talk a lot about cells and how they contribute to metabolic bone diseases, the cells only constitute around 2% of the entire structure of bone. The main constituent is going to be the extracellular matrix that you have. Within the extracellular matrix, the 70%, right? So the cells, as I said, is going to be 2%. In the extracellular, the inorganic matrix, which is the minerals, all right, which is going to be mainly the calcium and the phosphate, this is what is constituting the bulk, which is 70%, and the organic, what we call as osteoid, is going to be around 20%, plus there is around 8% water. So obviously you don't have to remember these numbers. I just want to give you an overview of what the bone is made up of. Now, when we talk about the diseases, either we have a dysfunction between osteoclast, osteoblast, or mainly we have a problem with the minerals. When we talk about the minerals, it's going to be rickets, right? So it's going to be rickets and osteomalacia, wherein we do not have enough vitamin D to form the calcium and the phosphorus, right? So a defect in mineralization is what we are going to see in rickets, osteomalacia. So this is the inorganic bone disease. When we talk about osteoid matrix, right, two diseases which go together are going to be scurvy and osteoporosis. In osteoporosis, there is a generalized reduction in this osteoid, whereas in scurvy, because we have a defect in collagen, right? I hope you guys remember that vitamin C is going to be responsible for hydroxylation of lysine and proline. When lysine and proline don't get hydroxylated, there is not going to be collagen which is formed. So that is why, because of a weakened collagen, now the organic osteoid is going to be weakened. So can you see a parallel between the bone diseases? So scurvy, osteoporosis go in one direction, rickets, osteomalacia go in one direction as far as the pathophysiology is concerned, whereas the other metabolic bone diseases that we are going to study, such as hyperparathyroidism or hypo-PTH, Cushing syndrome, so all of the hormone things which contribute secondary to bone dysfunction, all are mediated via the cells. There is a dysfunction in osteoblast, osteoclast. So I hope you understood the broad concept of why anything will lead to a metabolic bone disease, right? So this is what I was trying to aim at. Now, a bit more anatomy before we go into the radiology. When I look at the bone, we have the outer cortex, right? So the cortex is the solid bone here, which is rarely ever involved. What is more commonly going to be involved here is the trabecular. So the trabecular meshwork here, something interesting. So this is the trabecular meshwork. Something very interesting is that it only constitutes 20% of the mass. It is very, very loosely organized. So if I take 100 kg bone, which there isn't, 20 kg only is the entire trabeculae, which actually forms 80% of the surface. So this is an interesting number that you want to know about. And metabolic bone diseases are mainly going to involve the trabeculae. It's going to be this trabecular meshwork, much like how a building is formed, right? You have the pillars that they first make and then they put the cement over it, right? So it's the pillars. So what happens in osteoporosis is that these pillars just disrupt. So overall, there is no mineralization to be laid on, right? So this is the osteoid matrix which just disrupts. So this is what you need to understand, that in any metabolic bone disease, what are we going to comment on? We are going to say that there is a generalized reduction in the density. When I say a generalized reduction in density, it's going to be these trabeculae which are going to be having an altered appearance. So in any bone disease, however X-ray is going to be written is that there's an altered trabecular pattern. There is cortical thinning. There is an altered bone density, right? So this is what is the concept behind all of the things that we're going to understand. I hope so far you guys are following. Okay, so now let's begin. Whenever we look at any radiograph, the two fundamental things that you have to understand is there osteopenia or is there osteosclerosis? So this is where it all starts. Your approach starts here, and then we see the history, we see the biochemical parameters, and then you make a diagnosis. It's never that you look at the X-ray and you are like, oh, this is rickets. There are always other possibilities which you have to give out, and you have to look at the patient before you look at the radiograph. So this is what is the broad classification. Where would there be osteopenia? Osteopenia is what I report on the radiograph. Osteopenia could be a result of either more destruction or a reduction in bone formation, right? दोनों चीजें हो सकती है. End result is going to be osteopenia. Whereas osteosclerosis is always more bone formation, right? Osteopenia is what you're going to report it as. You never report it as osteoporosis. We write that there is osteopenia on the radiograph. Osteoporosis is the diagnosis of the patient. That is something very imperative that we understand, that my radiological report is going to say one of these terms. What causes osteopenia? So as we discussed, either vitamin D is not there, vitamin D deficiency, which is the mineralization, 70% mineralization not there, you will have loosened bone, you will have osteopenia. You don't have the matrix, you don't have the organic osteoid because of vitamin C deficiency. So vitamin C deficiency, which is going to result in scurvy. Osteoporosis, again, overall osteoid matrix is getting reduced. You have an overall reduction in the bone mineral density. Yeah, overall, both because the matrix is not there, there is no mineralization as well. So overall, the bone reduces. That's osteoporosis. And then we have endocrinological issues. Hyperparathyroidism will cause more bone destruction. Cushing syndrome causes a secondary osteoporosis. So I can just club Cushing with osteoporosis. It's a cause of secondary osteoporosis. Acromegaly. Again, acromegaly, that is growth hormone, is also going to lead to bone destruction. So when I have a lot of growth hormone, there's going to be more bone destruction, and thyroid as well, more bone destruction. So this is what you need to remember. When we talk about osteosclerosis, we are going to talk about secondary hyper-PTH. Secondary hyper-PTH is different from primary hyper-PTH because of more phosphate coming in. So it's not because of parathyroid now, but it's the phosphate which takes predominance. Wherever there is more phosphate, it sequesters more calcium, the bone appears whiter, the bone appears denser. Fluoride deposition leads to increased bone density. Paget's, we will see different phases. There are lytic, sclerotic, and mixed phases. opposite of what we studied here, hypo-PTH and pseudo-hypo-PTH, or pseudo-hypo-PTH, is again because of the phosphate increasing, leading to soft tissue calcification, bone density increasing, and heavy metal poisoning is what we'll cover in the end. So this is the broad overview. This is how you write your answer. This is mainly, this table is going to be invaluable when you begin your theory answer. Just as a snapshot, the examiner will know that you know metabolic bone diseases. And now with this, you have formed the base of understanding and your answer writing. Now it's all about spotters. So the other approach to this class is going to be to identify these spotters. So now your job begins. So tell me what the diagnosis. We're going to begin from the easiest of things and then maybe a few more challenging spotters. So this, I think everybody can diagnose. Correct. This is a case of rickets. So what you see in rickets, as it's not scurvy, it's rickets, right? So I'll tell you why it's not scurvy. So when we talk about rickets, as I talked about the pathophysiology, there is no vitamin D, so there is no calcium here. So there is no mineralization which is happening. Where was the mineralization going to happen? It was going to happen here at the growth plate. It was going to happen at the growth plate at the zone of provisional calcification, right? So there's a zone of provisional calcification just near the metaphysis. Because the calcification is not happening, all the chondrocytes are just waiting. Ki calcium aega, and there is hypertrophy. So there is hypertrophy of the zone full of unmineralized chondrocytes. When they apply pressure, what will happen? So now because of the pressure, the metaphysis begins to expand, trying to accommodate these cells. So there is going to be a cupping of the metaphysis that you're seeing. You're going to see it starts to become frayed. It starts to become very, very irregular. You see the basic fundamental thing that the growth plate dimension increases. So one fundamental difference between scurvy and rickets is here, epiphysis doesn't care. Epiphysis ko kya problem hai? Epiphysis is going to be completely normal. Whereas in scurvy, you will see that the epiphysis is also something which will be involved. So that's the first thing. Second difference is scurvy mein, don't you see it's the opposite thing? Scurvy mein I have calcium, but I have no matrix. Calcium kahan jayega? So there is no matrix. So there I'm going to see more density coming in. I'm going to see metaphysis appearing whiter, isn't it? So that's what we need to understand. So the fundamental change on the radiograph, as you all know, like from childhood only, you know this, that in rickets, the earliest sign is going to be that the growth plate increases in size. What else? The metaphysis becomes cup-shaped. There is going to be widening, which is called splaying, and then there is irregularity, which is called fraying. So these are the zones and the concept of rickets radiology finding. What do you see here on the chest radiograph? Anybody can tell me? And I've also shown you the image of the patient here. You can see that there is this bead-like growth. Yeah. So there is this bead-like growth that you want to see. Ma'am, the lucent area is metaphysis. No, that's the growth plate, right? So this is the epiphysis, this is the growth plate, and this is the metaphysis. We've forgotten basics only. So this is epiphysis, this is growth plate, which is lucent, yeah, and this is metaphysis. As the age progresses, this will be fused, okay? So this is meta, this is dia, okay? Right. This is indeed rachitic rosary. So this is widening of the costochondral junction. Why does that happen? Anybody can tell me why? ये कहाँ से आया? ग्रोथ प्लेट की बात चल रही थी. Why is rachitic rosary? Why is costochondral junction getting widened? Because it's the same, you know, when you go to your anatomy again, growth plate is a primary cartilaginous joint. So is, I will tell you, so is the costochondral junction, right? So because of the same funda here, the same thing that's happening at the growth plate, it's the same joint, which is a primary cartilaginous joint. So here also the same struggle of mineralization and cells waiting for calcium to come happens, and that's why you have this widening here. Okay, so this is what you want to remember here, that we are gonna have widening of the costochondral junction, and hence I call it rachitic rosary. So this is the widening, which is the rosary that you see. Now I am saying rachitic rosary because I know that it is rickets. Can it also be scurvy related rosary, which I call as scorbutic rosary. Yes, and scurvy also, again, as we saw, both are differentials, but with different pathophysiology. Scorbutic rosary can also happen, but this distinguishing factor is very little radiologically, more clinically. So scorbutic rosary, you will see, is more tender, because what happens in scurvy is that there is subperiosteal hemorrhage. There the blood vessels are also abnormal. Why? Because again, collagen nahi hai, so collagen is not there, so blood vessels very fragile, they bleed. Because of that bleeding, everything in scurvy is going to be very, very tender. So that's my first clinical distinguishing factor. If they ask you radiology mein kaise bologe, then these tend to be more pointed. These tend to be more rounded. So very, very subjective thing, but you see the bigger picture. You're not just going to see this x-ray. You're definitely going to see a joint x-ray, and that's how you're going to distinguish, right? So this is the difference between rachitic and scorbutic rosary. RRR, rachitic is more rounded. This is more tender and more pointed. Yes, you will also see Harrison sulcus, which is this diaphragm, getting pulled up when the person is doing respiration. Difference between rickets and scurvy will again get there. All right. So this is the difference as far as the rosary is concerned. In the bones, again, we'll talk about. Okay. So just stay with me. A few theory points that you want to write in your answer. So as you know, it's caused by vitamin D deficiency. Now, this is most commonly because of a dietary deficiency, that the person doesn't get enough vitamin D, particularly in children. Till 2 years of age, they need vitamin D supplement. The milk or the breast milk is not going to meet the RDS. So most patients don't know, especially in a country like ours. So they have deficiency, and that's why less than 2 year kids are the most common ones to have rickets. Okay. Apart from that, there may be malabsorption. As you know, A, D, E, and K are fat soluble, so anybody who has malabsorption can have them. Vitamin D active होने के लिए we need liver to form the 25 hydroxylase enzyme. We need kidney to form the 1 alpha hydroxylase. So either of them is a problem, will not have vitamin D, which is active. Vitamin D dependent rickets. What is vitamin D dependent rickets? Even though vitamin D is high, because of end organ receptor damage, there is going to be no effect of vitamin D. So this presents as resistance to even giving vitamin D, that is end organ. And then there may be genetic issues about rickets, which is mainly this vitamin D dependent rickets, or a type of hypophosphatemic rickets. Okay, so this is where you don't have phosphate getting absorbed. Biochemically, anytime vitamin D is an issue, what will happen? There will be no calcium and phosphate. Both of their absorption is going to be low. You will have ALP, which is raised, and PTH, which is raised. All right. So this is the biochemical profile, and this is what you need to write in your paper, and you need to understand. Anytime vitamin D is not there, both will go in the same direction. Because of low calcium, parathyroid increases. Because of PTH increase, bone repair marker ALP increases. Okay, so this is the biochemical profile. This is the clinical picture where you will see a lot of bony deformities, like you can see here. You'll see widening of growth. You'll see a protuberant belly. So these are the few things that you see clinically. Pathophysiology we have just seen, right? So this is the epiphysis. This is the metaphyseal end. So what we see, can you see in this figure only how the chondrocytes are proliferating? And this is the zone of provisional calcification where they had to get the calcium, but calcium nahi hai. So what will happen? All of these cartilage cell columns are going to rise, and they are going to press on the metaphysis, and they are going to cause its widening and splaying and fraying. Okay, so this is baby stuff, rickets. Can you tell me the diagnosis here? Yeah, protuberant belly may be seen. I mean, not very important. What is the diagnosis here? Good. So this is indeed healing rickets. Why is it not scurvy now? So this is what you need to understand, that what, again, I will reiterate the difference between rickets and scurvy, or more importantly, healing rickets and scurvy. So rickets में problem क्या था? Calcium का problem था, right? So what First of all will happen to the epiphysis. So my first point is epiphysis will always be normal, whether it is rickets or it is healing rickets. ठीक है, तो ये पहला point हमने देख लिया. Both of them will have reduced bone density, both of them will have cortical thinning. So that is not something that I can distinguish with. Both of them ultimately are osteopenia only, right? So that is something I can't use. So my first point is epiphysis. Second point now in rickets versus curvy is the regularity of the metaphysis. Rickets में कैसा metaphysis है? As we saw, irregular. Now you know why. So you will not be confused with the finding. Once you know the concept, you will not be confused with क्यों ऐसा. Irregular metaphysis, why? Because all of those chondrocytes are waiting and pushing on the metaphysis, right? So this will remain. And what is very important, now that healing rickets begins, that density problem will go away. Now what happens? This was going to be loosened in just rickets. The moment I give this patient vitamin D, everybody is very happy. Suddenly, all of those cartilage cells which are waiting now get their calcium. So suddenly, zone of provisional calcification pick, lot of calcification will happen, and you see what? You see a white line. So this is what is the white line of healing rickets. इसको हम white line of Frankel नहीं बोलते. This is just white line of healing rickets that you're gonna see at the metaphysis, because now the zone of provisional calcification is very happy. It has gotten all of the chondrocytes waiting. They've gotten their calcium and they are all quickly going to the metaphysis, and we get this white line of healing rickets at the metaphysis. White line of Frankel. Frankel word is for rickets. I hope this is clear to all of you that this is healing rickets. The trick is normal epiphysis and irregularity will persist. In fact, they say that the cupping actually increases. The cupping actually increases on the rickets healing, because now more and more cells suddenly are proliferating and coming because calcium aa gaya hai, right? So the cupping actually increases on healing rickets, and clinically if they ask you, the ALP is gonna rise. Okay, so you are gonna see, not rise, the ALP was high, it is gonna become normal. So it reaches normalization. Voice is breaking, is it? Deformity won't heal. Deformities will slowly heal, but yeah, it will depend. Okay. I think voice is okay. Bhagyashri, check your net. So this is going to be, is it? I hope it's okay for the others. So this is healing rickets. Look at this one. Now tell me what your diagnosis is. I've given you complete spectrum, including the biopsy report. Anybody who tells this will get one clap. No, it's not pages. Can you please show metaphysics of rickets and healing rickets? Okay, one more time I'll show, just wait. Very good, Upasna. So this is indeed tumor-induced osteomalacia. Very good. So what is tumor-induced osteomalacia? First of all, metaphysis देख लो. ये है ना, ये इसको metaphysis बोलते हैं. ये epi है, ये meta है. So you see how metaphysis is irregular and now white. A plain rickets का देखो. Can you see how this is the metaphysis which is loosened and irregular cupping? ठीक है? So this is what is metaphysis. Right. So why is this tumor-induced osteomalacia? First of all, what are these? When you see these unmineralized osteoid areas, these lines which would be usually bilaterally symmetrical, perpendicular to the bone, इनको क्या बोलते हैं? You guys know this from UG. These are loser zone, right? So these are loser zone, milkmaid's fractures. So these are the unmineralized osteoid. Again, osteomalacia is what? It is rickets, it's vitamin deficiency, but in a skeletally mature patient. So now I won't have this metaphysis wala issue, right? Because growth plate is fused. So now what I'm going to see is any area which has a lot of stress. Let's say there is some fracture or there is some vascular pulsation which is happening, the bone easily erodes there. And anytime bone erodes, the normal bone will try and repair. But here the repair happens, but there is no calcium. So just unmineralized osteoid gets deposited there. So all of these areas are called loser zones. Where do you see loser zone? Let's just talk about that first. So these loser zones or pseudo fractures are the deposition of unmineralized osteoid, any area of stress or along the nutrient vessels. Okay. So the common sites you want to remember, before that also remember, they will be perpendicular, they will be bilateral symmetrical. Sometimes they ask you, like what is the difference between a pseudo fracture and fracture. So these are the 3 points that you will write, that they occur along specific sites, whereas fracture can happen anywhere. They are perpendicular to cortex and they are bilaterally symmetrical. So these are the 3 differences. The sites, what will you answer for the sites which are common? So very, very common. In fact, the most common sites, can you see here also there is this break here. So the most common site is the medial part of the femoral neck. You can also see them, not in this case. Oh, in this case, you can also see them actually. So in this case, on the left side, it's superior pubic ramus, you can see. Apart from that, the ischium, lesser trochanter, scapula that we just saw, and posterior proximal ulnar.